So, Dr. Kevin Leach, welcome. Thank you so much for joining us this Saturday morning.
Great, thank you. I was honored to be invited, and any chance that I get to share about upper cervical chiropractic and how it helps lots of different stuff, I jump on the opportunity. So I'm glad to be here. Thank you. So I guess you can hear me and you can see my screen. Everyone?
Yes. May I ask what state you're in?
I'm in Washington State.
Fantastic.
Yes, originally from Delaware, so that's on the other side of the country. So, all right. Well, so obviously this is this is a presentation based on kind of just melding together what you guys do and what I do and what I've seen the relationship being. And I'm going to talk a little bit about what I've seen and talk a little bit about some of the research that's out there, a little bit of the co-management of some cases that with Dr. Taylor, who Barbara works with, and I just try to express a little bit about the importance of both of them and the kind of the chicken or the egg kind of concept of how they both affect each other. Just a little bit, I guess, a little bit about me. I'm trying to move forward with, oh, there we go. Okay, so yeah. So my story, I'm not a big fan when presenters get on and they talk about for 15 minutes about them and how good they are and all their accomplishments. I'm not really going to talk about that. I'm going to talk about how a little bit about my story and how it kind of relates to the TMJ, the bite, to kind of what you do, but not really. But I'll try to meld them and I'll try to make it make sense. So I had some health issues when I was in about junior high and even into high school. And I'm from a small town in Delaware, and they had chiropractors, and I think my mom went to one once, and I think I might have been adjusted once or something. But I was having health issues and nobody ever really could pinpoint what was going on. And it wasn't just like, it wasn't the typical health issues that most people expect a chiropractor would help, right? Like, so most part people like, oh, neck pain, back pain, maybe if they're a little bit more knowledgeable, they'll know that headaches are a part of it. I was having a lot of different stuff in a little bit in junior high and then definitely in high school. Different things like sleep issues, energy issues, skin issues, which probably were related to some other stuff, maybe puberty, maybe even dairy, and maybe some other things. But definitely, but also your neck pain, your back pain, and overall joint pain. And I was an athlete, and I was a 3-sport athlete, and it was really restricting a lot of my capabilities to progress and to do well in sports. I did well, but I actually stopped playing. I played junior college freshman year baseball, but stopped playing because the pain was so bad, and I figured I'd just focus on my education. But the point being is that my parents had no idea, and even today people have no idea what are all the things chiropractic can help, and let alone, besides just chiropractic, upper cervical chiropractic, and specifically the technique NUCA that I practice. So I went through undergrad, just lots of health issues, even saw a chiropractor in undergrad and got a little bit of help, but it was kind of like a natural Advil, and I got like a day or two of a little bit of relief. But I actually decided to be a chiropractor. The chiropractor I went to was like, hey, you should be a chiropractor. And I was like, all right, sounds good. I like people, helping people. And so I was a year into chiropractic school, and I was getting traditional chiropractic, and it still wasn't getting any better. It was still very temporary, and I was still just not healthy. And in 4th trimester, I was finally introduced to the upper cervical community, right? The upper neck specific techniques. And there's about maybe 7 or 8 of them at this point in the chiropractic community. And that's kind of when I, kind of dove right in and never looked back, because I saw the importance of it. I saw the changes in my health. I saw the history of it and the research behind it, and how important it is. The reason why it helped me so much is because the upper cervical alignment affects the cranial nerves and the nerves at the top of the neck. Excuse me. The C1, C2, occipital nerves, etc. And so when, and I even had this, I still have it a little bit, but I had this really big problem with my eyes, and I never knew what it was about until I got my upper neck adjusted. And so, as you guys know, your anatomy, you've learned we have 12 cranial nerves, and it turns out an upper neck misalignment can actually affect those cranial nerves. And so we've seen a lot of different issues, cranial nerve related, get help with the upper cervical work. So that's kind of my story from, getting into the, upper cervical chiropractic stuff. Let me go on to just the difference, because I can't imagine if anyone on here really knew the difference, I would be extremely surprised. Oh yeah, I forgot to share this one. That's my little guy there. That's Kyan. He's 21 months old. I thought that was a good pick. Thank you. That's his little grin right there. He loves jumping on my back, and he wants me to run around the house. So I thought I'd share that. So traditional and upper cervical. So real basically, traditional chiropractic it's been around a little bit longer than upper cervical, because upper cervical was what they kind of focused on and what they saw most of the results come from. If BJ Palmer is the developer of chiropractic, he's the one who, after 35 years of chiropractors adjusting the spine, they really found out that, hey, listen, if we focus on the upper neck, we're really going to get the most results, the quickest results, and the most reliable responses from the patient. So traditional chiropractic, the way that so when patients come in, they're like, oh, they want to know, what does NUCA stand for? What are you doing that's different? Oh, I don't want to be cracked, or, we get a lot of those patients, and we don't do the popping and twisting that the traditional chiropractic usually uses. Not that that's bad, I'm not against it, but it's a different result that we're going for. So the traditional chiropractic adjustment, the pop or the twist or whatever, that thrust that enters the spine, it does three main things. It restores range of motion, it stimulates the nervous system, and it releases endorphins, which from an immediate basis feels good and has an immediate noticeable change. And it's good, and it helps a lot of people. I get a lot of patients that have seen other chiropractors that either at this point in their life, they're like, I don't really think that's going to be good for my spine. I've got some degeneration. They call it arthritis. Like the patient calls it arthritis, even though it's osteoarthritis, but that's a whole nother thing. And so they want a gentle technique, or they've been to a couple chiropractors and I'm their last hope, or whatever it may be. And it's most likely because the traditional chiropractor wasn't focusing on the alignment part of the upper cervical spine. So the really big difference between upper cervical chiropractic and traditional is alignment versus movement. Excuse me. So in chiropractic, we have this word called subluxation. Subluxation is just a misalignment of a vertebra to the ones close to it that cause, any sort of neuromuscular, skeletal issue that could arise in the body. So again, traditional chiropractic is absolutely fantastic, helps tons of people. But if people have a significant enough misalignment in their upper neck, they're really not going to get the results and changes that they want, especially if they have more neurological type stuff, like your migraines, your headaches, your dizziness, your vertigo, even things like trigeminal neuralgia, Bell's palsy, if you guys know what those are. A lot of the kind of the head stuff, because those cranial nerves go from the upper neck, the brain stem, into the head. Those things can be affected. So it's really good to see. It's really good to give these people hope when they've tried kind of everything. So again, big difference is just kind of restoring alignment, spinal balance, and the goal of holding the correction. So we call it a correction or adjustment, the treatment that we do. So patients will come in and we do our analysis, we figure out their misalignment, we correct the misalignment. And I always tell people on their first, the day of their first adjustment, if I could give you one corrective alignment and you would hold that for the rest of your life, that's what I would do. And then I would joke and I say, I would charge a lot more for it because it would be a lot more valuable. But they laugh and they understand, okay, I guess that's not how the body works. They understand if there's an injury, if you cut your arm, or if, you tear your rotator cuff or whatever, healing takes time. So they're like, oh yeah, like it's not going to happen. They're like, oh yeah, they understand that if the body's misalignment, it has this misalignment, it's not just going to be corrected in one shot. Maybe some expect it or want it, but for the most part, people understand. And so what we see that after we correct the alignment, that people do actually start to hold that correction. So they'll start at some frequency, average around twice a week or so. And at some point they'll come in, I'll do my measurement, and they actually won't need an adjustment on that day. And so I explain that to them in the beginning, but on that first time they hold their alignment, I really make sure I'm like, do you understand? Because they're not used to going to the doctor, especially like a physical medicine or holistic, and not getting some sort of treatment, right? Like you'd never go to the massage therapist and they look at you and you're like, oh, well, you don't need a massage today. You're gonna be like, I paid for the massage, I want the massage, please, right? So that concept of not getting a treatment when you go is a little bit foreign. So I try to really emphasize, hey, listen, like you're in alignment. Your body's in the alignment that it needs to be for you to be healthy. Like this is a celebration. Like I took the confetti out of the ceiling, or else the confetti would have went off, right? Like because you held your alignment. So it's really, and then over time, the patients start to hold their alignment, and it's obviously when they're in alignment, their body's functioning better. That's when the healing happens, and that's when people feel the best. So a little bit different than your traditional chiropractic as far as goal of the outcome. I suppose that would be the explanation. I hope I went over that good enough there. All right, so we're talking today about kind of how why is the TMJ or the bite or occlusion, or some of the things that you guys might see or experience with patients or run across them talking about with the upper cervical spine. And so obviously coming out of the upper cervical spine, whether it's the nerve roots coming from occiput C1, C2, or whether it's from the cranial nerve, the facial nerve affecting the muscles, etc. Those two joints are super close together. And so it's the chicken or the egg thing. People can have an upper neck problem that can affect the nerves that are going to the temporomandibular joint, or people could have an old injury to the TMJ, which then puts strain on the posture, which then puts strain on the upper cervical spine, right? So it's like it's a dynamic complex there. I mean, the occipito-atlanto-axial complex that I work with is complicated enough, and then when you throw in all the muscles and nerves and everything from the TMJ, it makes it super complicated. So my experience with things like TMD, popping, clicking, pain, things like that, is I'll tell my patients, I don't really get too many that come in specifically for that. Typically these patients are, hey, like I'm coming in for headaches. Oh, by the way, I get clicking when I open my mouth all the way. Oh, by the way, I have, TMJ. Oh, there's no pain with my TMJ, but I was told that I have it, or TMD, but I was told that I have it. So what I do is I monitor everything that the patient complains about in the beginning. And lots of times people will say, oh yeah, like actually I'm not really getting that clicking as much anymore. Or, oh, I don't have the pain anymore, but if I open it up really wide, it'll click. And sometimes people are like, it didn't, like it's still there. The care didn't do anything. So we, just from an experiential, standpoint, I know that there's a connection there, right? And when the spine's working better, it allows the jaw to work better. So that's just from, that's from an experiential standpoint. I'm not sure that there's a research out there that it shows exactly, like, is it the cranial nerve 7? Is it the C1 nerve root? Like, I don't know that there's research that, again, this research is done by chiropractors. It's not done by the NIH, right? It's not, these aren't multi-million-dollar studies that are being done to look at this stuff. These are observations that clinicians have had over time, where they would correlate things, and the dental profession and the chiropractic profession, specifically of the upper cervical community, have been recently working together, saying, hey, listen, these two things affect each other. I think we need to get on the same page, and we need to work together with these patients and see if we can help them in an optimal way. So we're going to go through, did we do the overview? Did we look at that? Yeah, so we'll do three research studies, with the bite and upper cervical spine. Let's just go through those. I'm not going to bore you with, I'm not going to read you the entire things, but I'm going to hit the highlights of what they were going for. So this first study here, as it says, the influence of an experimentally induced malocclusion on vertebral alignment in rats, a controlled pilot study. So what they did, and this isn't a chiropractic journal, as you can see, the Journal of Cranial, right? So let me see if I can, there we go. Okay, so this study, pretty much what they did, they took two groups of rats, right? And they actually, they put malocclusion of the rats' bites to see how it affected the entire spine, which and what they saw was crazy. They saw that the malocclusion, like, they didn't do anything to the spine, but they saw that the malocclusion actually changed and gave them a scoliosis. And so they had 15 rats in one group, 15 in the other. The control group, obviously, they didn't, nothing changed with those, but the 15 rats that had the malocclusion, they all developed a problem. And then it said 83% of them, when they took it out, kind of restored the balance of their spine. Here is the kind of the pre, post, and then post, right? So you've got the x-ray of the rat just before the application, and then 1 week after the application. And so you can see just this scoliosis, starting to form there. And then after they take it out, they do another one and they see that it restored. So they were just really trying to figure out how the bite and any sort of malocclusion, any sort of TMJ jaw issue affected the spine. And so this is a study that upper cervical chiropractors use a lot, especially with the dental profession, to show them, hey, listen, the bite's important with spinal health, and they affect each other. The second one here is craniofacial changes after combined atlas orthogonal and biomimetic oral appliance therapy. And so this one, they were trying to look at kind of the same thing. So what they did was they took their patients, they found that they had a jaw issue, they had an occlusion issue, and they also had an upper cervical chiropractic issue. And so what we do as upper cervical chiropractors is we take x-rays, and specifically NUCA and atlas orthogonal, just like it said in the study. It's from an orthogonal standpoint. And when it says the Cartesian analysis, here in the abstract, it might be, right there in the objective. What we're looking at is we're looking at the head straight, the atlas kind of horizontal to the ground, and then the neck straight up and down, like crosshairs on a rifle. And anything that deviates away from that, we consider misalignment. And we try to get everything back into the frontal plane and everything back on to alignment. So these patients, they had a spine upper neck problem, they had an occlusion problem. So what they did was they did the X-ray analysis before, they did the X-ray analysis after the adjustment, and then they did the biomimetic device, and then they did another X-ray, and they actually saw that after they put in the biomimetic device, the oral device, that these alignments got even better. And so once again, implying that the bite and correcting anything in the mouth and the jaw has an effect on the spine. And in that case, since they corrected it, they saw an improvement in the spinal alignment after they put in the application. And so a little bit more information there in case anybody wants to see. I know these slides will be shared with everybody in the future. So let's see, study number 3. So the relationship between craniocervical orientation, again, this is in cranio, and center of force occlusion in adults. Okay, so this one, again, just noticing that there's a difference. This is done, so Dr. Westerson, so as you see the authors there, Dr. Westerson and Dr. Schulten, they're up in Canada. They've worked together for a long time. They have a funny story of how they met, but they've been working together for a long time, just referring patients back and forth, doing this exact thing, saying, you know, Dr. Schulten would see a problem in their occlusion, or their bite, he'd do a screening, he'd send them over to Dr. Westerson. Dr. Westerson would do a screening and say, hey, listen, you need to go get your upper neck, you know, aligned too. And so those two working together, they get kind of that optimal treatment, that optimal restoration of function. The author from the previous study, sorry to be jumping around, but the author from the previous study, Dr. Chapman there, had Dr. Singh, I believe, Dr. Singh or another dentist actually in his office. And so they worked side by side doing all of this for several years. I don't believe he's still there, but they did work together for a long time. Okay, so what they did, this one is they used the T-scan. I'm sure you guys have heard of that. They're just looking at, you know, the bite and the pressure points from all the teeth coming together. And so what they did was they did pre-X-rays with the upper cervical spine. Then they did the adjustment, and then they did they measured they measured it with the T-scan. Excuse me, got a frog in my throat. Sorry, hold on. Okay, so what they did was they measured the bite with the T-scan before the adjustment and after the adjustment. Now, this one was super interesting because what they found, I think there were 14 or 15 subjects. I can't remember. It's probably said it in the abstract. What they found was not every one of these patients actually had an improvement in the bite, which was super interesting. Probably not what they expected, but I have a little theory about what potentially could have happened. So if you see the subject number 10 before adjustment, after adjustment, you could say, oh yeah, okay, that looks more balanced, right? But subject 11, you're like, okay, it looks balanced on the left, and then after the adjustment, you see that shift to the right. Now, I don't know why this happened. My guess is that when somebody has been misaligned for so long, and the body adapts to whatever is going on, and the bite, you know, could potentially be balanced, and then you shift things in the upper cervical spine, whether it's posture, whether it's head tilt, center of gravity, etc., you can have obviously an effect and a shift in the jaw as well. So, you know, even though, and again, this is kind of a preliminary study, this isn't a huge study, but even though it seems like a negative response, still the result of what they're seeing here is, hey, listen, when we adjust the spine, when we adjust the upper cervical spine, it affects the bite, right? So it's just, you know, like every other research paper, it says more research is warranted for this, to see what the relationship is and what the effect could be. So that's the third study. Just again, all these studies just investigating. Hey, what if we measure this? What if we measure that? How does the adjustment affect the bite? How do all these things affect each other? So now we'll get into kind of like a screening exam that you could potentially do if you're interested, while you're either seeing your patient or right before or right after, something, super quick that you could do, to say, and most of the time these patients may have in their history or may mention, oh yeah, I have jaw pain, or even when you're working on them, they open their mouth and you can see the clicking, hear the clicking, or see the jaw kind of pop and move. These things are probably right in front of your face that you see every single day, but it could be indication for a referral to an upper cervical chiropractor. I don't know if there's an upper cervical chiropractor in South Africa. I know that one of the attendees is from South Africa, so I don't know if there is one, but it could, even if it's not upper cervical, it could indicate even just somebody working on the upper cervical spine. So the first one, front-facing posture analysis standing. So I've got some football players here that were, just doing this every day. I think it's on Sunday evening. They have a football game and they kind of do these, they're like, they have a shot that the football players come up and they say, hey, I'm Joe Smith from North Dakota University. Hey, I'm Bob Wright from, Yale or whatever. So as an upper cervical chiropractor looks at posture and alignment all day, I'm always looking at their posture. Is their neck straight? Is their head tilted? Is one of the shoulders high? Like what's going on with their alignment? So I've got three different examples here, of different alignments of different players, right? So and these are subtle, right? So when you look at your patient there, you can just literally stand them up in front of you and look straight ahead. I have a line chart that's parallel to the ground so that I can see where their ears are, I can see their neck and shoulders, etc. But if this guy was in front of you and you look real closely, you could see, oh, okay, like his right ear is a little bit higher than the left, and then his eye, like you can see there's a little bit of left head tilt. It's not a ton, but it's a little bit there. When you look at if you look at the lines of his neck, you can see both of them are very, very straight up and down. You can make the argument a slight, left neck translation, but it's pretty minor. And then you look at his shoulders, you see that his right shoulder is high, his left shoulder is low. And so those would be factors that I would look at, to see, okay, he's potentially got a misalignment in the spine. I should go back to one thing just because I realized I didn't explain it. So when I do my exam and I'm looking for an upper cervical misalignment, that's not on the x-ray yet because I haven't taken the x-rays. I'm pretty much examining them to see if they actually have a misalignment. Posture is one of them because the misalignment in the upper cervical spine puts pressure on the brainstem and the spinal cord, and the first area that it will put a tension or a pressure on are the nerves that control the posture. And so we see that after we take the x-rays and we correct the alignment, their posture will actually improve. Shoulders balance out, hips balance out, not completely all the time, but it's correlated and it's related. And so we look at the whole spine as a reflection of what's going on in the upper cervical spine. So looking at this player here, he's got the left head tilt, right, high right ear, and he's got a low left shoulder. That would be one of the indications of saying, yep, he's got a misalignment. Let's take an x-ray to make sure and then measure it so we can precisely correct his specific misalignment. So that's this player here. So moving on to the next one. This one's pretty obviously pretty obvious when you look at the right neck translation. If you look at the side of his neck, you can see on his right side, it's straight up and down. On the left side, it's kind of going inward, right? And those little lines kind of indicate that. His ears are pretty level. You can make the argument, again, if you look super close, that his right ear is a little bit higher, but he's got that big right neck translation, and he's got that low right shoulder, high left shoulder, which would again be, indication this guy's got a misalignment. We should take X-rays. One of the indications. And then this one right here, you can see everything is pretty straight on, very symmetrical. Ears level, the neck, you can look at the line of the neck on the left and right, straight up and down. Shoulders are level. So this part of my exam, looking at that, I'd say, wow, he's pretty darn straight. He would have to have some other deviations and some other positive tests in order to indicate that he has that misalignment. On a side note, I've always been interested to correlate how many of these players get injuries, more so than the ones that have less misalignment in their posture. Like if we were to take 20 of these players and we were to line them up and say, okay, what's been your injury history? I would not be surprised, and I would be fascinated to see if the players that had the more symmetry and less of a misalignment in the spine had less injuries because of the efficiency of the biomechanics in the spine and thus in the extremities, because the nerves come out of the spine to the extremities to balance things. I'd be really curious to see if there was any correlation there. Maybe I'll have to do that study in the far future. So that's posture. So again, you can just kind of see, as if I scroll through here, you can see the deviations that these players have. So the occlusion pathway, this is obviously something you can do just immediately as they're laying down or in front of you. I had a little video where I videoed myself doing it, but obviously it's just opening the mouth and closing the mouth, right? So you just have them open the mouth super slow, maybe take 3 to 5 seconds to open up all the way, and then 3 to 5 seconds to close all the way. And you just see, is the jaw tracking up and down, or is it jutting over to the side? Is it clicking? Is it popping? That's gonna, that could very well indicate some TMJ function, dysfunction, but also could indicate, hey, there's something going on with the upper neck as well. And the last one here is just palpation, and maybe you all have been taught this as well, but you pretty much you can palpate the TMJ. You can have them open and close. You can palpate just right, just an inch behind, right below that mastoid, and palpate around there to see if there's any pain or tenderness, any clicking, any sort of problems there. And again, this is all just real quick. You can just pop your hands on there and just see. You can ask the patient, do you have any tenderness? You can just kind of almost give them a little massage and say, hey, is this tender? Is the left side more tender than the other? Looking for asymmetries. All those can just kind of give you hints of, hey, maybe you should go get your upper cervical spine checked out. It could help you out. So in conclusion, the upper cervical alignment, neurology, function are interconnected with that of the TMJ, occlusion, and bite, and that's what we've been going over this whole time. There's definitely been experiential, clinical, clinical experience with that, and also in the research. There's not a ton, but there's definitely we can see some sort of connection with those two. An issue with the TMJ or the upper cervical spine could affect each other to varying degrees, right? Everybody's going to be, different. Problems in the upper cervical spine can cause a myriad of issues. Life is better in alignment, so get your spine checked. So there's my little guy. Again, super happy there. So let me, I think everyone else is muted, but if Barbara, if you want me to jump in here into the chat maybe and see if there's any questions there. I see there's a 5 in the chat, so I'm gonna just look at this.
There are 2 questions, Kevin.
Two questions, okay.
Yep. Can you get it?
I see. Okay, yeah. Question: were the patients assessed for proper occlusion in the first place? Is this referring to maybe one of the studies?
Yes. I think it was the
So,
third study. Shannon, do you want to pop
With
in
the
and
teeth? Yes.
oh,
I was curious
yeah,
about when can you hear me?
yes, yeah.
Oh, okay. When you were discussing the studies, those two studies, there was
Mm-hmm.
participant 10 and 11
Mm-hmm.
for the T-scan assessment
Mm-hmm.
and
Yeah.
measurement. The patient 10 had a more intense and balanced bite, and then 11 was more counterintuitive and had a better, more balanced bite. Were they properly assessed with their with their occlusal plane in the first place? And did they
The
have
only
a history of ortho?
Yeah. I don't know. I'd have to read the whole study again, but I believe it was pretty much T-scan before adjustment, T-scan after, right? And I do realize there could be a lot more variables in
Yes.
that as well. And I think again, that's why these studies, it's probably, I think it was like 14 patients, 15, 16 patients. These are just preliminary. Hey, like, can we see a correlation here, right? They're looking at any sort of change that just happens with the adjustment, probably even regardless of the history that they had before. I think the main question they were trying to answer is there an effect on the bite when we correct the neck? I think that was pretty much the main question that they wanted.
Okay, so it's just
Yeah.
basically an effect, not necessarily causative or determining as
Well,
far
yeah,
as
I mean, that's kind
function,
I mean, that's
dysfunction, and proper occlusion.
yeah, I mean, that's kind of with any research, it's hard to account for all the variables. But they were looking, yeah, again, they're looking for what the adjustment, what the upper cervical alignment changed about the bite. And that, I think that's what was interesting to see. Sometimes it changed it in the way that it was more balanced. And on a couple of them, they saw, hey, it is actually more imbalanced. So your question is necessarily like, well, what was their history of ortho? Have they had other work done? And now that the spine is balanced and the nerve are balanced, maybe that caused, a worse T-scan after, right? So yeah, so they're just looking at what, is there an effect of the upper cervical alignment on bite? And they made the assumption yes, but further research is needed, as most research says.
Okay. And also, do you do any muscular re-education and manual traction?
No, not in my office. I'm not against it, but my office is very, I would say, efficiently run, in the sense of, the time that I spend with my patients is pretty much for aligning their spine. Sometimes I'll actually give with a very basic, it seems kind of silly of an exercise. I'll actually encourage my patients to yawn and literally just yawn and just open the mouth, open the mouth, open the mouth, just to kind of get some stretching and some kind of increased and restored range of motion there. But I'm not, I don't do, the traction or the massage or anything like that. I didn't really talk about anything that I do with Dr. Taylor, but Dr. Taylor, who Barbara works with, she uses and used the DNA appliance. She works, she does a little bit of this stuff as well. We've had patients back and forth that we've worked with together. I think that she might give some of those exercises and some of that guidance to her patients as well. But like I said in the beginning, I don't typically see these patients specifically for TMJ, for TMD or bite issues. It's typically like, hey, I noticed this after care, right? Like it's rare that someone's coming to me specifically for that, unless Dr. Taylor, sends them over, specifically for that. And sometimes it's not even a TMD issue. It's just she's doing the DNA appliance, and she's doing pathway work or airway work and things like that. Does
Don't you
that
find
answer
that
everything?
Yeah.
Yeah.
Do you find, I mean, I'm not a dentist. I have a
Mhm.
huge history in dentistry and periosurgery, but I am not a dentist. I do complementary alternative medicine and blood chemistry analysis and things of that nature. But I have I specialize in body work. And I have a lot of patients that are athletes and also musicians, especially sax players and horn players. So there's a lot of tension here. And I mean, some of their muscles are just like insane, especially the
Yeah.
sax players.
Totally.
But I'm finding a lot of impingement because the muscles are so hyperdeveloped, and that's what's locking in the spine.
Mhm.
And it keeps them in place, but there's so much pressure and so much muscular buildup that once that is released, and by the way, I've done like literally 3 hours of deep tissue on some of them. And that just scratches the surface on getting those muscles relaxed so they're able to actually have an ambulating joint.
Yeah.
So
Yeah. So you're saying you're asking,
translates into the face as well.
yeah. So are you asking like, do I incorporate that or
Yeah.
something along those lines? Well, I have, again, I have a referral network of massage therapists and body workers and all kinds of stuff. I haven't worked with too many musicians or too many people that are super locked up like that, like saxophone players or something like that. But nonetheless, there's definitely a repetitive motion or occupational, problem that people can develop that sometimes it's hard to get around. It's like, well, this is what I want to do. Like, I want to be able to play my saxophone and these muscles are hyper developed. Like, what do we do? And I'm absolutely for the body work and massage or rolfing or whatever it is to restore normal function. And most chiropractors are going to kind of be on the same page with that. Like we kind of believe in the body's innate ability to heal itself. You just have to give the body the right environment to do so. So I absolutely have, I have several massage therapists. I have acupuncturists, I have holistic providers, I have naturopaths, I have a good wide array to work with. And I would also encourage the mobility stuff, right? Mobility in the neck as opposed to just stretching. And I've got a couple different videos that I've created for my patients that I'll send to them to kind of target joint function instead of just like stretching. I call them yes, no, maybes because you do like, the yes and no, and then you kind of do side, the ear tilt side to side, that's your maybe, but it's less of a stretch or exercise and more of like a targeting, like let's get motion into those joints. And so
like with usage of a TheraBand kind of a thing as well?
No, just so there's
just
yeah.
autogenous.
Yeah. So just, without any sort of resistance. Well, especially because these patients that are under care with the nuke alignment being so gentle, we don't really want to put a ton of stress into that system to make it to force it to misalign right away. So the yes, no, maybes are the first one is just, it's a very, very slight movement. It could be maybe a total of like 10 millimeters in total. You're doing you're keeping your entire cervical spine still, but you're really targeting the upper cervical spine. So you're doing flexion, you're doing rotation, and then you're doing so flexion, extension, rotation, and then lateral flexion, right? Again, so the way I think about it, I tell people, like, imagine two bowls of the same size sitting on top of each other, and you just kind of slide the top bowl around, on top of the bottom bowl. Like, you're trying to target the joints inside the spine to get those moving. And then the other one I give is I have them do those motions, but I have them go to their complete range of motion and hold for 30 seconds. But I encourage them not to go too hard to stretch the muscles. We're trying to get it to end range to get to target the joints. There's nothing wrong with the stretching, but it's I want the patient to focus on really getting to that end range of motion for those joints, and so I incorporate those as well. So alignment, joint function, and then, you know, the soft tissue work is going to be, yeah, kind of your full package there.
Are those also applicable to people with history of neck surgery, oral surgery, and also having had an implant surgery kind of history?
I would say so. Obviously, patient to patient is going to be different. I take x-rays on every single patient because the technique, you know, that's the protocol. So I'll see any sort of, you know, even if sometimes patients literally forget that they had neck surgery. And you're like, I see a plate, you know, like I see a plate between your C5, C6, like what's going on here? But even then, with my technique that I do, there's no twisting, everything's in a neutral position. So it's rare that there's going to be a contraindication to adjusting. But any sort of surgery or any sort of change in biomechanics being the key word there, of the jaw or neck, can have what's called adjacent segment disorder, where, you know, the segments, the biomechanical segments around that can start to degenerate because of the lack of complete function from that prior surgery. So I think to answer your question, I don't see too many that would have contraindication to care. But yeah, there's some.
Thank you. I don't want to monopolize the floor. I could go on all day.
Yeah. Well, so I see Barbara told me there was or somebody popped on here and said, please, do you have any ready take-home tips for patients with trigeminal neuralgia? Unfortunately, no. I mean, you could try those yes, no, maybes that I just explained that may help, but you 100% need to see an upper cervical specific chiropractor who does NUCA, atlas orthogonal, if somebody's going to focus on the upper cervical spine. If you want to see a small book or read a small book called What Time Tuesday, it's called What Time Tuesday by James Tomasi. It's his story of having trigeminal neuralgia so bad that he planned his suicide, and his wife kept trying to find different doctors, and he literally planned his suicide on a Tuesday. And his wife, a few days prior, said, hey, I scheduled you an appointment with a NUCA doctor, you know, to see if we can help. And he's, you know, the title of the book is, he said, okay, well, what time Tuesday, right? Because he had other plans that day. And so NUCA literally saved his life, saved him from committing suicide, because it gave him the help, and it got to the cause of the problem. Now, disclaimer, is every trigeminal neuralgia problem an upper cervical problem? Probably not, but upper cervical chiropractors have seen a significant amount of change, enough to say, hey, this could be a very big cause of this problem. So, you know, when you're looking at your boxes to check off to see like what's the cause of this problem, an upper cervical chiropractor is definitely on that list for patients with trigeminal neuralgia. All right. Well, Barb, am I cut free, or?
I have one other question. This is just basic curiosity. With the rat x-rays, the three slides or the three images that you showed us, the rat had, you know, the upper limbs were up and extended, but some of them were like, you know, kind of like not fully extended. Do you know if they were attempting to put the same exact limb extensions, you know, to be even? Because I noticed in one of them, like in the middle one, where the scoliosis curvature was quite pronounced, you know, the pelvis was also off. Because I mean, you can make things kind of
of course, you can definitely, so you know, again,
I'm curious.
I wasn't there for the study, obviously. Like you know, it's like I don't know how, you know, exactly how they did this, but they tried to show, hey, listen, this is how we did the radiographs, right? They try to show the you can still see my screen. I have the research
yes,
put up here. Yeah. So I think I'm not, so yeah, so the ratchet traction, preparing for the radiograph. And then this one
Kevin,
here.
I'm sorry, Kevin, all we have is a blank. Let
me see. see if I can new share. There we go. It's because I wasn't sharing the screen. Let's try that.
There we
There
go.
we go.
Okay,
There we
much
go.
better.
Okay.
Thank you.
Sorry. Okay. So scrolling back up here so you can see like they're putting the it looks brutal, right? Like, are they like sleeping? Like, what's going on here? Anyway, so yeah, they're trying, it's small, these things are tiny, right? They're trying to line them up and whatnot. So I think here, I mean, yeah, like they're like, you can see like the hands and the elbows, they're at least the same, right? This one maybe a little bit not, but this is really the one that they're trying to show. I mean, elbows are across and knees are across, right? So it's like they're at least being hung from the same place, right? So
I'm just
I
wondering
would
if the
say,
work was balanced and if the positioning was an attempt to be
of
balanced.
course,
And did-
course,
And they
yeah,
adjusted them afterwards. So
yeah.
so
I
I'm using
mean, yeah. So yes, I mean, as a chiropractor, especially with who does X-rays, and I've been doing it for so long, yeah, you can change and you can shift different things in X-ray to make things look in a different way, right? I can't speak to the integrity of of what they were doing, but I don't know, I don't know any sort of like reasons why a cranio or dentists, non-chiropractors would be trying to prove, that it causes scoliosis, for some, lack of integrity.
I'm just not familiar with the journal
yeah,
personally,
yeah,
but
yeah,
like
yeah,
if they're on the Cochrane database, I have a little bit more
yeah,
credibility,
yeah,
associated
yeah,
with it.
yeah,
Yeah, because it's peer reviewed. So
yeah.
I'm curious about the methodology and everything.
Yeah, I mean, yeah. Well, I mean, I'd have to read through it again and see. But
Are these studies available on like when we go to get like the resources from this meeting?
So I don't know if I'm allowed to share them. I know one of them is open source. I'm not sure about the rat study. You might need subscription to that one. I mean, both of those are in Cranio, but I know one of them is not available because it's like a private subscription based journal. It's called McCoy Press. It's the vertebral subluxation. Let me see if I can pull it up. Is it this one? No. So yeah. Oh, so it's this one. So this is the Annals of Vertebral Subluxation. This is kind of a subscription based one. I can see if they're able to be shared, but the recorded video should at least have the authors and the titles so that you could do your own research and see what you can find them.
That's my middle name, research.
There you go.
Every day.
Yeah, and yeah, I have for anyone else who's interested in just upper cervical things in general, I do a research podcast where I do a lot of review of upper cervical research with a good friend of mine, Tyler Evans. If you YouTube Progressive Chiropractic on YouTube, you'll see me and maybe 20 or so, 25 episodes so far with upper cervical.
Great.
Yeah.
All right.
I hope
Any
all
more
of you,
questions?
yeah.
A question. I'm sorry, I couldn't find the chat button over here, so I couldn't put my name on it either, Barbara.
Okay,
So
I've
I'm
got
actually
you down.
driving, so yeah, sorry. Thank you so much. So my question, Kevin, is that I'm a dentist. I work with airway and some TMJ work as well. And I was just, and I apologize, my 3 kids are in the car with me. So my youngest is probably a month older than yours. So
Nice.
so what's happening is that what I would like to know, like, would you recommend like first getting the cranial work done before we start working on the TMJ or sleep issues and stuff like that? Because for sleep, I do work with chiropractors and osteopaths, kind of like release the fascia, like the the cranial, not the craniofacial work, but basically like fascia around the neck, because that releases the tongue ties and stuff like that.
Right.
And we do, I do have an orthogonal chiropractor I have gone to in the past.
Yeah.
And so I'm just wondering, like, what, and I'm surprised that I did not know about this. That like it's a chicken or the egg situation, basically. What would you recommend first?
Yeah. So in the past, working with Dr. Taylor, we first started to do like she would send the patient over. They'd have their first day exam and X-rays, and then we would correlate to where immediately after their first alignment, they would go and get fitted for their appliance. And as time went on, I'm not sure we even discussed this, but she started to just send people over and say, hey, get under care, start to get the upper cervical spine stabilized, and then we'll address the appliance in the future once everything starts to, stabilize and get better. So if possible, I would recommend some care prior to working on the jaw and with any sort of appliance or ortho appliances.
All right. So thank you so much. That was really
of
helpful.
course. Absolutely.